Thank you. Good morning, everyone. Thanks, Sheila. It's so great to be here. I'm coming back next week from PDL sabbatical, and so excited to be back and to see familiar and newer faces. I've got to meet some of the new CA1s at our newbie simulation course in July, right before I took off. So wonderful to be back soon. I am speaking today about emergency manuals and the data from simulations to clinical uses. And I'm going to be giving an overview of both the experiences designing, testing, implementing, and researching these. And I want to start by saying that any project worth doing really takes a village. And in this case, it has truly been a team of teams and a global village, both at Stanford and around the world. I'll be showing you later our core team of the Stanford Anesthesia Cognitive Aid Program. But I wanted to just mention upfront that we could not have done this work over the past decade plus without the real collaboration amongst the entire simulation group, Larry Chu's AIM Lab, the education, quality, and leadership of our department and hospital, and specifically the divisions of MSD and OB have been extremely involved in what has been a huge culture change and implementation that started here at Stanford in many ways about a decade and a half ago clinically, and rested on the shoulders of the many decades of work prior to that that David Gaba and Steve Howard had led in their cognitive aid work prior to that. And we've collaborated with folks around the world. I'll talk to you about EMEC, the Global Emergency Manuals Implementation Collaborative, and the folks who founded that with us a decade ago, and then the great rise of these tools. So could not do this alone. And the many residents and faculty at Stanford have also given tremendous feedback with each iteration. I see Pedro Tanaka sitting in the back there. He's been one of our many translators, teams collaborating in the 8 languages that we've worked with folks to translate around the world, and really appreciative to each of you. So disclosures, no financial interest with ineligible companies. I put on here my honoraria and leadership affiliations, as well as not specifically for emergency manuals, but consultancy for teamwork and safety culture with no healthcare products involved. Learning objectives I've put up for the CME slide. I'll let you guys read briefly. All right, so I wanted to start getting into the fun bit of this with a little bit of interactive questions early on a Monday morning. So I want you to think back to a challenging crisis that you've been involved in. You could have been an observer, you could have been leading it, coming to help, and be given that this is Stanford, where we've implemented emergency manuals quite a while ago. I'm going to ask you to think of one without the use of an emergency manual. A challenging crisis, and think about some adjectives. How did it sound? How did it feel? How did it look when you were at this crisis in the OR or elsewhere? So I'm asked for some brave volunteers. One word adjectives.
Scary.
Scary, thank you. More.
Can we do synonyms?
Okay. Huh? Frightening, excellent. Chaotic. More. Who else? Anybody been at a crisis? How did it look? How did it feel? How did it sound? Scary, frightening, chaotic. Any more? All right, I often hear around different institutions, noisy, the frightening, scary, chaotic. We have these emotion words, we have these noise words, we have the disorganization or the chaos. And you are not alone if you felt any of these things, whether or not you shared these adjectives. Thank you to all of you who spoke up. I'm going to play for you a very short clip. It's just a little over 10 seconds. And you'll recognize some of the people in this. This is filmed at our simulation center, but it's not scripted, and with permission of the folks in this. This is from some years back in one of our Evolve courses. And all the folks are more senior now in new roles. But you'll see this is after we've implemented many years before already, and after we've trained with emergency manuals and the familiarity with them. And this is a crisis in the simulated PACU with the use of emergency manuals. I want you to compare just the feel and the adjectives of this to the words that you all have shared.
All right, so let's summarize. At this point, we have secured the airway. We are doing quality chest compressions. We did listen. We heard bilateral breath sounds. So just going to our H's and T's.
So you can see there a sense of calm and organization. We often hear from folks, we were literally and figuratively on the same page. There's an announcement of the event that we're in. There's chest compressions going on while you can see your reader and your leader standing next to each other, and the tasks are delegated. So this by no means just emergency manuals alone. There's a lot going on there to make that work well, but hopefully that felt and looked different from your adjectives. And I will tell you, in case you think that's just a simulator artifact, there are plenty of chaotic, noisy, loud, frightening simulations. If you've ever been involved in a crisis simulation, you'll know that your heart rate can be up quite high as well if it's put together well. And it's fully possible to feel all of those words you said in a simulation. This is actually takes a lot of effort to make it this way. So kudos to that entire team. This is a slide just showing graphically as a cartoon, the idea that we have all the stacks of literature. We all study medical and technical skills for many years to become expert in those in our own fields. And then we have this idea that we want to deliver that complete optimal care to our patients. And there are a number of barriers to that, especially during a crisis, some of which you named. So I put this up just to give context. Sheila mentioned my background simulation and patient safety and human factors there. And the teams I work with, I'm really interested in the problems within and healthcare and within other safety critical industries with high hazards. In this idea of what are the other things that it takes for our teams to provide this complete optimal care to our patients, and what helps support those medical technical skills to enable that. So we're focusing today on this using cognitive aids and the emergency manuals, but all of these CRM key points, which have a long history way before me at Stanford and around the world, are also really key in that. So this does not work in a vacuum. So defining emergency manuals, these are context relevant sets of cognitive aids used for critical events, also known as crisis checklists. And we're going to talk today about why to use emergency manuals with the rationale, both from healthcare and simulations. There's been a lot of evidence base there, but also even before that from some of these other safety critical industries and the literature on that. And then we're going to dive quickly into the clinical implementations and uses, which is really exciting. In the past 5 years or so, there's been much more literature on that than there ever was. So the why. Astronauts, pilots, nuclear power operators. These are some of the many fields who share with us this idea of dynamic decision-making by expert professionals in the setting of intrinsic high hazard conditions. And all of these fields use and train regularly with emergency manuals as an expected part of their crisis response. That doesn't mean it's the first step, obviously. In healthcare, we want to be on chest compressions when a patient's heart stops, not opening a book and staring at it. And this was a major cultural barrier at first, certainly when I trained. I think for many of you in the room that it was related to this concern and valid fear, I think. But there were names like cheat sheet and you should know it all. That I see nods here. This was not how you care for a patient. And by no means am I saying it's the first thing you should do. Obviously, we want to have first hands on life-sustaining treatment. But we'll talk about some of the data that shows that we actually benefit and our patients benefit from consulting these rather early on. These are some slides from integrated in-flight simulation training. Some years ago when I had a FAIR grant, we did a collaboration back and forth with Virgin America where we visited them and they visited our sim center, and it was actually interesting to learn from each other. I thought we would learn a ton from aviation, and they actually told us how much they were learning also back from healthcare simulations, which was kind of interesting. So here's the flight simulator that we got to go in, and pilot cockpit. So the why of human factors, one of the fun collaborations has been with Dr. Barbara Burian of NASA Ames, and she and her colleagues have taught me a lot about the memory under stress, prospective memory error, and latent knowledge, these issues about our human brain. So if you think of your memory this way, and this is our memory under stress, and some of the literature there, that you are not alone if you feel like a deer in headlights when you have that crisis. What I've found personally is the moments where I feel that are very different from 20 years ago, but the feeling is the same. And those of you who have rotated through the Sim Center know that we also focus on sort of methods to ground ourselves and to help our brains to be calmer under stress. And your favorite attendings who show this really well, and senior residents who demonstrate it really well in a crisis. These are really valuable skills. So here's some of the healthcare data that this builds upon transitively. So this one makes intuitive sense, but it wasn't until 2014 that we had really great data to show that it matters what steps we do during a crisis. In this case, it's ACLS protocols, and this is the association between survival of in-hospital cardiac arrest to return of spontaneous circulation. So this basically shows that it matters whether you follow the guidelines or not. And here is the divergence from the ACLS protocols. And again, you can see that when there were errors of the wrong action, the wrong timing, or omission of key actions, that mattered to the patient's survival. So kind of common sense, but really important that we have this data that shows that those guidelines. So building transitively with this and the simulation-based data, I'm putting up this slide for an overview of the prior decade of the early 2000s, where we had the simulation evidence mounting that with emergency manuals, with crisis checklists or cognitive aids, we can help teams to deliver these correct intended actions. And I'm going to focus on just a few of these to give you a little bit of the history and the important data from that decade, and then move on to the clinical implementations and uses. So this was led by Dr. Kyle Harrison back in 2006. This was a little bit before I came to Stanford, and was actually part of the reason I was really excited to come collaborate at Stanford. Kyle was doing this work when he was a fellow, and I had visited and was finishing up my fellowship in Boston, and was noticing the same things in our simulations. And we had some really interesting conversations about this. And this might seem obvious now, but it was kind of a new idea there, that the frequency of the cognitive aid use correlated significantly with the MH treatment score, meaning the resident teams that used these cognitive aids, that picked them up and actually looked at them and used them to help them manage the event, they managed the event better. And so this was early days of saying, well, if we want people to follow the guidelines of these rare crises that are hard to remember and our brains under stress are shrinking, and if it matters in clinical world for our patients, how much of this optimal care we can actually deliver in the moment, then how can we help these clinicians and teams in the moment to feel less stress, to access those guidelines easily in a way that's designed for bedside use, and to actually pick them up. It turns out that each of these had their own challenges. So this is a paper out of our Ariadne labs from the Harvard group that was in the New England Journal in 2013, and the world started paying more attention to the idea when this came out that there was a 75% decrease in failure to adhere to critical steps. So that's huge if you combine that with that earlier slide, that matters what care we deliver to our patients for ACLS or for crises, and we can decrease the omissions and the errors of failure to adhere to these critical key steps by 75% if we can get people to use these appropriately. Here's a more recent study by colleagues in the Netherlands. I spent time with these colleagues over the past decade, and a number of folks at Stanford have been really helpful in helping them get a national cognitive aid in the Netherlands going for the OR. They then took this work and extended it to surgical wards, and they found a very similar result that with these cognitive aids for medical decision making in these critical surgical patients, there was a 70% decrease in omissions in critical management. So the same idea in a different context and different directionality. Here's some work from our ED colleagues in Germany who've gotten really interested in the subject and contribute a bunch to the literature showing with and without checklists and the median percent of the interventions performed. So hopefully from these different demonstrations of the quantitative data, you're seeing this in different ways and hearing the same story. In Australia, ED sim-based RCTs, both pediatric and adults for numerous events, they're showing not used versus used and the total errors. So hopefully that section has summarized more the decade of simulation-based work to convince you of the take-home message there that these can help clinicians and teams to do the right thing more often. And with that slide transitively, that this may matter to our patients. So that's where we were at about 5 years ago. There were a number of case reports. We were getting a ton of emails and anecdotal evidence saying, thank you to the Stanford team, to the emergency manual implementations collaborative. This saved my patient's life. Our team used this in a big city, a rural village, a hospital. We downloaded. We had this, when they had anaphylaxis, their heart stopped. This was really made a big difference, but that was all anecdotal. And the case reports were building up, but were all case reports. So we really wanted to look into how about real OR crises during actual patient care, which obviously is a harder question. So we started working on this idea of clinical dissemination, adoption, implementation, and uses, but really studying that with mixed methods, combining quantitative and qualitative to figure out how do we see if this matters in the real world, which obviously is different from the simulation center. Around almost a decade and a half ago now was this global collaborative, the Emergency Manuals Implementation Collaborative. And this was something I was really excited to be part of founding and love working with, because everybody in it shares their tools and resources. So they're designers of cognitive aids, there are implementers, there are researchers, and everyone has agreed that will be all shared freely. We have a lot of our Stanford grads who contact us after they've graduated who want to implement. And the idea was we'd make a toolkit. There was AHRQ grant that we worked on to be able to share this toolkit for free. And then everyone who's used it has contributed back. So we learn as much from the implementing institutions, and we've taken many of the ideas, our pocket manuals that hopefully many of you have received, the little pocket emergency manuals that came from a group at Vanderbilt who measured the size to fit in the scrub pockets and handed that back to us. Our close collaborators at MGH, we've learned a lot from as they've implemented, and we try to integrate that and then to say, adapt, keep the core, adapt the periphery, share back what you learn. This is a picture which is from about 8 years ago. And this was from a study of implementers of both the Stanford and the Ariadne Harvard crisis checklists in just the first couple years. So this was the first 10,000 downloaders we sent out a survey to, and this was just the 1,700 who responded. to show where these were implemented. And globally, folks have implemented these, as far as I know, on every continent except Antarctica. We're still waiting there. I know if we redid these dots, there would be a lot more of them now. These were photos sent by colleagues. This comes in the far left here from Guatemala. We had global health colleagues, and I want to call out our global health team who have done tremendous work in education, both using and adding and tweaking these emergency manuals in their education work. So they went down there with copies and digital versions printed to be able to teach. And they got to this rural village in Guatemala and they emailed and they said, hey, you won't believe it. Look what I found Xerox hanging on the rural village's anesthesia machine before they had gotten there. In the center, you'll see the adapted versions from our Dutch colleagues. And then on the side, there's a Mali labor and delivery ward where they have the poster on the wall for their cognitive aids. These are from colleagues in China, sent to me by Dr. Jeff Wang, who's done a lot of translation and implementation and training work there of a number of emergency manuals, and has spread it through the WeChat app and had hundreds of thousands of downloaders and adopters there. So this is an overview conceptual figure that Steve Howard and I worked on together for a paper now about a decade ago. And what we were trying to do is to bridge from the simulation literature, that early 2000s literature I was describing to you, that these work, these increase the adherence to the right events, and yet nobody uses them in the OR. And so we had this gap and wanted to conceptually figure out what will it take. And everyone knew that we needed some optimized content. We needed to take 30-page guidelines and literature reviews that were much longer than that and condense it to a page or two that was usable in real time and needed to be designed in a way that would be helpful to the clinicians. But what we went is we went back to study in aviation and nuclear power, and talked to forest firefighters, and to see what does it take to actually get these to be used optimally in the system. Because we realized that even if they were designed well, that they weren't going to jump out of people's pockets and their phones, they weren't going to jump off the walls, and that they needed to be there. And so at Stanford, we actually had an amazing resident who I still remember coming to us and saying, SGF, I would use this to save the mannequin's life. I know it will. And this was around 2009 or so. I said, I would use this because it will work. And I would use it. I'd like to use it in the OR, but there's no way in hell I'm pulling that out in front of X. And there was this culture sense that it was not okay. And I don't say this to blame Stanford. This is how the whole world was. And that really made me realize that there was more than this content design we had to work on. And the next month, Dr. Ron Pearl came to us and said that there had been an event, that the surgeons had come to him and said, isn't there a group working on these cognitive aids in the SIM Center? And we had an event. And without going into the details, it was a PEA cardiac arrest with multiple senior attendings who were very, very wise people, and the patient was bleeding, and everything was done towards bleeding, but nobody thought of pneumothorax, and the patient died of a tension pneumothorax. And the surgeon said, how do we bridge what's going on in the simulation lab with our ORs to help bring some of this work? So we had the residents saying, I would never use this because of fear of consequence and culture. And we had the surgeons and Dr. Ron Pearl coming and saying, like, how do we get this there? And so we wanted to combine the training and familiarity, the access and roles, and not just making it available physically, but saying this is not only okay to use, this is part of our culture. This is hanging here. This is this big red book. This isn't you're making it up or pulling it only out of your pocket. And then the culture change. And even though it may seem like a number of years ago, having this kind of culture change, within years and within a decade has been really impressive at Stanford. And I still visit places where, they say to me, I see the data, I know this would work, but there's no way Dr. X would be okay with that. And there are other places, it tends to take about a generation of residents, about 3 years, when people have the desire to implement well and follow some sort of a roadmap and toolkit and adapt that to their institution to have a complete change in culture, as we've seen at Stanford. So this is a cartoon. I'm curious for any guesses of what decade this quote comes from. If a response is not instantly obtained by simple measures, a fixed emergency routine pasted on the walls of every operating room and drilled into every member of the staff should be enforced. What decade do you guys think? Wild guesses. I promise I don't bite. 1980. Thank you. More guesses. Decade. You can shout it out. 70s, 60s. Anyone? Do I hear 50s? Okay. This is from 1924. And it's from Dr. Babcock. We're coming up on the 100-year anniversary. And you'll recognize in there a lot of these concepts. And this was shared with me by Dr. Bill Berry, our collaborator that we founded together, the EMIC Global Collaborative. And it was right after Dr. Steve Howard and I had published this conceptual diagram of what we thought it would take. And you can see in there, in that quote, there's the content and design, there's this, and then there's the access. It's fixed on the poster on the wall. And his words are a little bit more mandatory than ours are, but the idea drilled into, there's training involved. It's not just the first time you've seen it. And should be enforced. We like to think of the culture of enabling use and permission rather than enforcing, but the idea that this is okay, that I've heard in other grand rounds that folks are saying during grand rounds during M&Ms that this was used, or if it was not used, which can be appropriate as well. By the way, we have plenty of crises where it's not appropriate, where it resolves too quickly, or you don't have enough hands in that moment. To talk about them and to ask as accepted culture. Okay, so training, I'm going to flip through these kind of quickly in the simulation lab. Throughout the years here at Stanford, we familiarize, we try to have people know the overview and the design before they even pick it up in the simulation center, and certainly in a clinical crisis, so it's not the first time you've touched it, and so, importantly, so you think of picking it up. It's very common for any of us in the moment to actually, that neuron next to the one that forgets the dose of the dantrolene might forget that there's something, 2 feet from my hip that has all that information in it. And so we need to remember to trigger use at the appropriate moment. The access, we found the principles are that it needs to be a consistent location, easy to see and reach, but not block daily workflow. So thankfully, most of the time, we're not in crisis mode and we want to be efficient to get through our many cases or our big cases and not have this be in the way. So these were 2 early examples at Stanford and at Mayo that applied these principles. We then had at Stanford, we had feedback from Diane Alejandro and the anesthesia techs and our committee, that when it was hanging on the side here and they had all the circuits to hang and the other stuff that we need for every case, that either it was getting buried or it was getting tangled or it was in the way of things. And so even though it was very visible, it wasn't following this principle of not blocking daily workflow. I was very excited when our colleague, Dr. Eloise Sultan, came up with a solution for this. She put stickers on the screen there of the computer where you're looking, and a QR code if you ever want to scan and download it on your phone. And then she put stickers on the drawer of the codonics, and you can see where it is in the drawer. So on the one hand, it's not visible all the time, but the stickers and the consistent location are supposed to make it so that we can find when we need it. Here's some pictures from our MGH colleagues who are implementing about a year after we did at Stanford. You can see the pocket version I mentioned from Vanderbilt, and they were working on mobile versions to have on their phones that we've then developed these internally hyperlinked ones. And we then were very excited to be able to also provide this on the electronic health record system. So big thank you to Dr. Cliff Schmiesing, I see sitting there, and to the entire EPIC team for working with us on this. I don't know, maybe already 6-8 years ago, Cliff, like a while ago, it managed to integrate this into these macro buttons. So you'll see this E on the side of when you're in the interop view, and then you'll see at the top of your entire screen, many people don't even know this is there, but any view you're in, pre-op, intra-op, MDS view, you can see this little button there, and that will create a pop-up that you can click to. It's not the best for in the middle of a crisis, because often your back is to the patient, you're right in the way of the medications, but for teaching or looking up things or a quick dose or something, or if you don't have your handy paper version, it can be a way to jump around to the right event very quickly and get that information. So we found that having the small pocket, the big hanging, the on your phone for transport or mobile, and then the EHR has been for different contexts and different people a good solution. This is our version 4, and the team that created this who really worked for multiple years to put this together with entirely new design informed by human factors. And I wanted to call out specifically here both Dr. Barbara Burian and Dr. Naila Austin, who did tremendous work on the design of these. You can see a sample design there when you're in your ORN board later today. If you have a moment of calm, you can flip to the back and you can see this design overview, and it goes through what is the organization of the ACLS events first in red and the other ones alphabetized, and then the tabs that you put your finger on and flick it open with the one hand. And so then we were responding to the clinical data that I will show you, as well as the feedback at Stanford during clinical and simulations to create the new events that people were requesting. So you can see the overview here and a sample trauma event that was a new event with this version. So when you're setting up your trauma room, if that's something that you want to just check you have everything, you can see on the second page of your trauma events, you'll see go to next page there. And on that second page, you'll see a checklist of things to set up. But they're always set up so that the emergency things are first, and then the preparation is on the second page, or the rechecks. So culture, the all-important culture, each strategy for lunch, hard to define and change, and really important and easy to feel. That's something that's evolved over time. And we think that the training, the familiarity, the successes, we had initially some faculty who said, this is great for the residents, but I don't need this. I know all of these events. And as we interviewed folks and talked to people, not only at Stanford and MGH, but around the world, we found, well, if it's this event that I don't deal with ever, and I don't do local anesthetic toxicity, well, maybe it would be useful to have that dose of that medicine, but I don't need, the bradycardia. And that's fine. Not everybody needs everything. But I've yet to meet any anesthesiologist or physician or expert who in a stressful moment has all of this content in their heads. And that includes all of us who have worked on this for decades now, that because of those issues of memory under stress and the fact that it takes 10,000 hours of expertise to really have things at the tip of your tongue, nobody is expert in all of these. And we found that often it's the resident who pulls it out to recheck something and to use, who is the one who says, could this be helpful, or wants to speak up with this idea, and that these emergency manuals are then making someone feel psychologically safe to share an idea that maybe even they had already, but were nervous to say, or just because they've trained with them and it's not culturally foreign to just read off and check. And that's how a lot of the faculty actually have said, like, oh, I knew 95% of it, but it helped my patient because it reminded us of these two small points. A really common one we see, which everybody, I promise you, will get right on the boards, and a multiple choice question, but I can't tell you how many times it happens in simulation or in real codes. The anesthetic is left on. Now, we obviously all know that we need to turn off the volatile anesthetic or the propofol during a code, but we forget to do it. So that's a great example of sort of a low-hanging fruit of just a quick check. Okay, so caveats. This is important. There was worry, especially early on, that you'd have doctors staring at books and not treating their patients. And this is one of the studies that added to that concern. This was pediatric residents, not anesthesiologists. And there was failure to perform chest compressions on a pulseless patient. So this is the last thing we want. We do not want to distract. We do not want to have someone reading a book instead of treating a patient. I'll show you the cognitive aid they were using. And the explanation that's been discussed for this has been that, especially when they weren't trained in depth on all of the subpoints and didn't have as much, ACLS training as anesthesia residents would have, that when they're seeing this for the second or third time and it's during a crisis and they're trying to navigate all of this and they're staring at it, the design is not actually so easy to use with this fine print and all of the details involved there. And they don't have the training with the aids in advance. And they don't have as much of the ACLS training that the first thing you do is you jump on the chest. So I'm pleased to say that both in our communally thousands of simulation sessions, as well as in the anesthesia studies that have been done, this doesn't happen. In fact, the opposite happens. You'll see someone pick it up and then put it down to go back to the patient. And then half an hour later, when they're struggling and feel like nothing's working, forget to pick it up still. And you'll see people in the moment where it's refractory and unfolding, but not realize that it's right behind them. And so we've actually done a lot of work with interprofessional trainings and with the sim sessions to empower people to say, even if you're not the one who will be using it, and to not all put it all on the leader. So for any of you who arrive at a crisis, one of the things you can do if you're a person who walks in and there are no hand tasks needed is you can say, would it be helpful to grab the emergency manual? Or you can say, which event are we on? Would you like me to grab that? And we've had our scrub techs speak up and say, hey, doc, do you want the red book? And every time I've heard it offered, the leader's answer has been yes. There are moments like VTAC, that is unstable, needs shocking and gets better, that it's not at all needed. But the vast majority of the issues are actually in triggering use. So think about that if you're the next person in and no hand tests are needed, that you can ask the leader. It doesn't all have to come from the leader to sign it. So approaches and protections, awareness of these pitfalls, the design, the training and familiarity, and the team help. This is a design paper from Dr. Barbara Burian, which is an amazing overview of the field in both aviation and healthcare. And so for any of you interested in working on design of these kinds of things, I highly recommend this. We've now had more than 1 million downloads globally of the various emergency manuals and crisis checklists through EMIC. And if you go to the tools and resources, free tools, you can access both the actual content as well as the implementation toolkits with trainings, videos, and roadmaps and suggestions for how to make those more helpful. So implementation studies. I'm just going to show this briefly because most of you are not actually implementing these. Feel free to email us if you graduate and go somewhere where you want more information on this. But this is to say that there's a dose response effect. So it matters to have this in different areas and to go through these different steps of the toolkits. It's not just one thing. And the number of ways of the tools were used was related to the implementation successes in terms of reported clinical uses at appropriate crises. These are some summary overviews of that work. So clinical uses. This work I'm really excited about because it was the question that we got asked the most even 3 years ago. We did in-depth interviews with more than 50 anesthesia providers, a lot of folks at Stanford and at Mass General. And the clinicians described emergency manual use or non-use in 80 applicable OR crises with 69 unique events. The numbers differ slightly there because people could have multiple crises. Crises could evolve into different events, but you get the idea that going from case reports, this was then the first big study actually looking at this data. And we looked at both quantitative and qualitatively. So you can see the ACLS crisis as well as the non-ACLS with the EM used and not used for the variety of events. And the EM was used in a total of 37 of these 69 unique cases, so more than half. And you might think that's a low rate, but this was going from both these institutions never using it pretty much a year and a half before this. And then if you take out those events that resolved too quickly for appropriate use, it was 2/3 of the relevant crises. So this was tremendous cultural adoption in the space of less than 2 years. This is a joint display for any of you who are interested in mixed methods research. This is one of the ways to present data that has both the quantitative numbers, which are important in summarizing, as well as the qualitative. So I'm just going to put up a quote there from one of these. So you can see on the left the categories of the themes of stress, teamwork, and atmosphere. Our team searched actively for anything either unhelpful or distracting, and always asked active questions during these hour-long interviews to search for any way in which the emergency manuals may do harm. And you can see that we actually found 3 of these events in teamwork, where it was actually found to be distracting or unhelpful to teamwork, though with a deep dive into each of these in the paper, there were also the other side where it helped the teamwork. So we searched actively for these. We found none that actually, if you go to the next slide here, we found none that actually harmed the delivery of patient care in the clinician's view. And for those distracting ones for teamwork, we also found that it helped, but we were able to then iteratively change our design and our trainings to mitigate those factors where it could harm in any way, even the teamwork. So you can see one of the quotes, and this was just hundreds and hundreds of thematically qualitatively coded quotes, and very different from our anecdotal emails, but seeing the same themes that we've been seeing for the past prior 5 years. So here, the EM was very helpful in PEA event because we hadn't thought about hyperkalemia until he read through it. So as a result of the manual being used, we were able to consider and treat something critical earlier. And this was a variety of attendings, residents, CRNAs at both institutions. We also looked in this study at reasons for emergency manual non-uses. And we were really interested in why they weren't used. So you can see that 10 of these crises out of the 32 were too brief for EM to be used. And you can see some of the quotes for that. And as the qualitative interviewers and the thematic team agreed with these assessments, that was appropriate non-use. And then you had these 22, and the major reason was nobody suggested to use the EM. So if you remember back, I said that one of the biggest challenges is triggering use and suggesting it. And when someone suggests it, almost always is used if it's not that, flash event. But within that, you can see there were identified omissions or delays in delivery of patient care. And that is per the clinician who was recalling these events. So we did an in-interview exercise where we actually had them open it to the event, and they went through, and for each step they said, done, not applicable, or, oh, that would have been helpful. And so this was per their review that they identified omissions or delays. And you can see some quotes up about that. And then there were these 4 identified no omissions nor delays. So within those 22, there was a small proportion where that attending was expert in the event and had seen it 100 times before, and they really didn't need it. So this top box and the bottom box, we think, might be reasonable, appropriate, though we still like to model the checking after the fact of the use. And you can see that a large number in this middle box, folks said it would have helped. And because of these issues of memory and stress and during it. And so that's why we encourage people to have these touch points, and either if something is getting a little bit better and you have a pause moment to try to think and build into your routine of when I have that moment, then I'll check through or assign someone. And the other big one is when everything's going worse and nothing you're doing is helping, and you're doing the same things and you think it should help and it's not responding, that's another great checkpoint. So I have for myself a rule that, if something's getting worse, even though I've done something that should make it better, then I may either assign someone or call in more help if I don't have the parallel processing bandwidth. You can see here a quote, the cause seemed pretty clear that it was a hypovolemic asystolic arrest and trauma patient, but pneumothorax, we didn't think to rule that out. In retrospect, it would have been good to assign someone to check for that. Now, this patient may or may not have a pneumothorax, but that story I told you before, that is a common one that's missed because the things that treat everything else in PEA obviously don't treat a pneumothorax. And so if we're chasing fast down bleeding, but we don't treat pneumothorax, it doesn't help that we got, you know, 95% on the H's and T's. So this is a recent study that came out this spring. I want to call out Dr. Anna Frackman, who did tremendous work for a number of years on this study that looks at sustainment from 2014 to 2021. And this is exciting data because it was the first study that actually looked at any denominators. You'll see that the percentage use is very small, as it should be, because most cases hopefully don't have crises and don't need emergency manuals. But this was in hundreds of thousands of cases at Mass General, where they collect data at the end of each case, similar to how Dr. Will Gustick and Dr. Ashley Peterson, the QI committee, have started to implement here. So we had this data of all cases that were answered, and we were able to add a separate question about emergency manual use. And this is just the peri-crisis use. So this doesn't count looking up a phone number. This doesn't count educational review unrelated to patient care. This is just, it was used in relation to a specific patient, either during a crisis or just before to get ready for something that this patient might have, specifically in their case, or right after to debrief, a lot of them during uses. And you'll see that, like any innovation, when it's implemented, this was a year later, point B, you had a drop in uses. So 145 cases out of these, roughly 25,000 down to 42 when it was less pushed all the time and you didn't have this pop up every case to remind you to do it. But then there was the sustainment to 2021 where it actually over time, sustained / went up a little bit. And if you look at these numbers, these were for less than 6-month periods. So that meant an average of about 10 peri-crisis uses per month for actual patients where it was contributing to their care. And the EMs were used in more than half of perioperative cases with cardiac arrest or ACLS in 2021. So it's the first data that we have to show sustained use with denominators over time. And there's been a lot of excitement about what that means for changing the culture and changing the care we provide. We think that this is one of the drivers. So this is very similar to early culture surveys we saw from Stanford residents. When I told you that quote about the resident who said, I know it would save the simulator's life and I know it would save my patient's life, but there's no way in hell I'm pulling it out. So fully trained anesthesia professionals should use EMs. That was going up over time. The culture where I work supports EM use. This third question we think was a wording change that caused the dip in 2015 after 1 year. So having EMs accessible could improve patient care is theoretical, whereas improves the year after is a different question. But very excitingly, in 2021, does it improve patient care? The vast majority of people think yes in 2021. And then colleagues may think I'm less competent. That went from 20% down to less than 4% there. So we've talked about why emergency manuals can help our teams and our patients. And we've talked about clinical implementations and use sitting on the shoulders of those decades of simulation data and iterative design. And hopefully I've given you a sense of the global collaborative as well as the tremendous number of teams at Stanford who have contributed to these efforts. I'm happy to take any questions and a big thank you to all of you. Please continue to share back your ideas.